Good afternoon and welcome to our webinar, which is a partnership of the National Patient Advocate Foundation, the Association of Community Cancer Centers, Oncology Nursing Society, and the Community Oncology Alliance. We welcome you. I'm Rebecca Kirch from the National Patient Advocate Foundation, and we're thrilled to welcome you to this webinar this afternoon, Solutions in a Time of Crisis, Ensuring Safe and Effective Pain Relief Through Good Policy and Practice. A very, very hot topic of high interest right now, so we're delighted to introduce our faculty for today's webinar, which is being recorded and will be circulated as a link to share with your colleagues. And we hope, too, that you will complete the brief survey after the webinar when you close out. Today, we are featuring Dr. Judith Pace and Dr. Bob Twillman, who will be delivering the webinar and taking questions at the end. Dr. Pace is the Director of Cancer Pain Program in the Division of Hematology Oncology, as well as a Research Professor of Medicine at Northwestern University, the Feinberg School of Medicine. And Dr. Bob Twillman is the Executive Director of the Academy of Integrative Pain Management, which is formally known as the American Academy of Pain Management. But that integrative addition, as we'll hear today, is an important clarification of what complex pain management now involves. I'm going to turn it straight away to Bob Twillman to begin the webinar session. And a reminder, you have an opportunity to ask questions by using your chat box on your screen, and we will hold questions till the end, but be sure to get to them at that time. Thank you. Bob, please start.
Good afternoon. It's a pleasure to be here to be able to talk about this important topic, as Rebecca mentioned. And I want to start by showing you what I think a lot of us feel like these days when we're trying to manage pain. We're kind of like the great Carl Walenda here on this cable over a canyon, trying to stay on the straight and narrow, doing the very best we can to provide a balanced approach to pain management, and knowing that if we fall off, all kinds of bad things can happen to us and to our patients. And it seems like it's an even more challenging environment every day as the winds kind of whip up and down the canyon that he's walking across and threaten to blow us off the wire. So it really feels like, I think a lot of times today, it's a real challenge to stay on this straight and narrow. Part of that is because what we're doing is really dealing with two very significant health problems in this country. One is the problem of prescription drug abuse, prescription opioid abuse in particular. With the latest data from the National Survey on Drug Use and Health tells us that about 12.5 million Americans use prescription opioids non-medically every year. The cost of that to our economy is about $100 billion per year, give or take, depending on which cost you look at, and about somewhere in the vicinity of 16,000 to 19,000 people die of overdoses involving prescription opioids every year. On the other hand, we have the problem of cancer-related pain, which we know is a significant problem, has been for a very long time. Approximately half of all people with cancer experience significant pain. If you do a cross-sectional survey of patients who are walking through your cancer centers, your hospitals, in general, the pain becomes more common and more severe as cancer progresses, so that by the time you get to advanced cancer stage 4 and so forth, 75 to 80% of people can have severe pain. And we know that pain in cancer survivors is becoming increasingly common, and that pain can oftentimes last for years, sometimes for the rest of the patient's life. So we're having to find ways to deal with all of these issues and not wind up causing ourselves some problems. And I think a lot of times this feels to us like it's a sort of a zero-sum game. Because I think a lot of times we feel like anything we do to prevent prescription opioid abuse has to be accomplished through the mechanism of reining in the prescribing of opioids. And when we rein in prescribing of opioids, and we do that in a non-discriminate manner, what happens is that that can also have the potential to decrease the pain relief that we're able to provide to people who have pain. And at the same time, I think it often seems to us like anything we do to improve pain management has to involve prescribing more opioids, and that runs the risk of making the problem of prescription opioid abuse worse. The good news is that I think that's a misstatement of the truth. I don't think it really is a zero-sum game. I think it's possible to address both problems without adversely affecting either one of them if we're able to provide balanced pain management. H.L. Mencken said, "For every complex problem, there's a solution that's neat, simple, and wrong." And the problem here is that we're dealing with two complex problems. The problem of prescription opioid abuse is a very complex problem. The problem of cancer pain relief is also a complex problem. But what tends to happen is the policymakers tend to, when they detect that we have a problem, they tend to reach for very simple solutions to solve those problems. And when they reach for simple solutions to complex problems, that's when you wind up in a situation where you have negative unintended consequences. And I think that may be part of what we're seeing happen right now in the context of pain management as policymakers reached for solutions to solve the prescription opioid abuse problem. Perhaps what we should be doing is really seeking complex solutions that will solve the complex problems rather than seeking just the simple solutions. To get those solutions, we first have to ask the right questions. To get the right answers, we have to ask the right questions. And I think a lot of times in this context of how do we solve the problem of prescription opioid abuse, we have not asked the right questions. It's important to note here that most of the concern that people have with respect to pain management as it relates to prescription opioid abuse has to do with treating chronic non-cancer pain that's not related to cancer or to cancer treatment. And that is what's driving a lot of the current policy development. But the problem is that the solutions that they come up with tend to bleed over into the cancer space and to cause problems for us when we're trying to provide optimal care for people with cancer. So again, we haven't always been asking the right questions, and I think one example of that is this. So many times people have been asking the question, should we use opioids to treat chronic pain? And they find that a very seductive type of question because it leads you to a yes or no answer. A very simple kind of yes or no, yes, we should use opioids, no, we shouldn't use opioids, but I don't think it's that simple. I think the right question really is the one at the bottom of the page. In which patients should we use opioids? At what doses? For how long? With which adjunctive treatments? With what precautions? That's a much more complex question. It's the kind of question that when providers and policymakers think about it, it tends to give them headaches, which is sometimes a good thing. These are things we need to struggle with in order to figure out how do we best address both of these problems at the same time. I think that the careful and judicious use of opioids with both pain relief and patient safety in mind is what's appropriate. Opioids are necessary, but we have to use other tools as well. And this statement is something that we wrote several years ago on behalf of the Academy of Integrative Pain Management to say that within the context of this integrative model of care that we promote, a model that relies not just on opioids and not just on things like epidural steroid injections and so forth, but also on all the other ways we can treat pain. Relies on things like chiropractic care and acupuncture, massage therapy, psychotherapy, and also on patient self-management techniques, getting patients to exercise, to manage their stress better, to eat better. Using all of those things together, we can achieve the goal that we set out to, which is optimal pain management. And within the context of that model, we recognize that opioids are part of a comprehensive plan for some people who experience pain. Not every person needs an opioid. Not every person with pain needs an opioid, but many do. And that's especially true, I think, of people who have pain that may be caused by cancer or caused by cancer treatment. When opioids are used judiciously by well-educated clinicians, and when they're taken as directed by patients who are well-informed about the medications, these opioids may be useful in reducing pain and restoring function. The appropriate treatment for both chronic non-cancer pain and cancer pain is a multimodal approach, and it includes interventions like exercise, nutrition, the integrative medicine treatments, and other medications besides the opioids. because there may be others that work better for some patients. Primarily what we're interested in is not getting the patient to zero pain, because that's a pretty unrealistic goal in lots of cases. But what we're really interested in is how do we improve the patient's quality of life and the patient's ability to function. By using this multimodal approach, we think that we can actually reduce the reliance on opioids as a primary means of treating pain, while at the same time giving the patient what we're trying to give them: good relief from their pain that allows them to have a good quality of life and high quality or high ability to function. But there's some barriers that keep us from being able to provide that type of pain. Maslow said, if all you have is a hammer, every problem looks like a nail. And the problem that we've had for too long is that when we're treating pain, we tend to think that we only have one tool, and that's the hammer of opioids. And so we've been hammering away at people with opioids, trying to get their pain under control, and not thinking about the fact that we have other tools that we can use and that we need to be able to access. If you think about pain from the biopsychosocial perspective, which of course is what we encourage people to do, then we're recognizing that we need to use multiple tools to fix the system that results in pain. Unfortunately, the system that provides those tools is broken, and we need more tools and better access to the tools we have. In order to get that, we have to do a better job of educating people in their sort of traditional training programs. By that I mean medical school and nursing school and so forth. Better education about how to use this integrative approach. We need to have continuing education for licensed providers who never learned this approach in treating pain. We have to have enough providers to provide non-medication treatments in particular. We've got to have access to referral networks, and we've got to have adequate reimbursement so that people can afford to provide this care and so that patients can afford to access it. Many of these treatments are not covered by insurance, and patients have to pay out of pocket for them. What is covered is medications. And so it's relatively cheap to give somebody a lot of opioids. But if you want to have them get a massage, they have to pay out of pocket, and sometimes one massage costs as much as all of their pain medication for an entire month. Increasingly, one of the things that we're doing is we're seeing government agencies issue guidelines for the treatment of chronic pain. They tend to be very heavily focused on the use of opioids in the setting of chronic pain. And it's really important to recognize that every one of these guidelines is based almost entirely on expert opinion, and I'll show you why that's the case in just a moment. The CDC guideline that came out in March of 2016 is a prime example of that. Even though it's said to be an evidence-based guideline, it really is based largely on expert opinion. And here's why I feel comfortable saying that. In September of 2014, the NIH sponsored a 2-day program on the role of opioids in the treatment of chronic pain. Before that program, they commissioned the AHRQ to do a review of information of the medical literature on this topic. They presented all of this information at a meeting. There was an unbiased panel of people who heard all of the information, read all of the reports, and at the end they wrote a report based on what they'd heard, and they said, there's insufficient evidence for every clinical decision that a provider needs to make regarding the use of opioids for chronic pain, leading the provider to rely on his or her own clinical experience. So this expert panel, looking at the very best evidence gathered by NIH and other government agencies, is saying there is no evidence to guide us when it comes to the use of opioids. But lack of evidence, as you may know, rarely inhibits policymakers who see an opportunity to make policy. And so what's happened is governmental agencies can establish laws and regulations and guidelines to alter opioid prescribing patterns. It's important to note that many of those policies specifically contain exclusions for pain related to cancer, or for cancer pain, as it's often termed in those pieces of policy. But what we often find is missing is a definition of what cancer pain is. So Does this only include pain that's caused by the cancer itself, or does it also include pain caused by cancer treatment? Many times when you see a definition, it will be incomplete and will only say pain caused by the cancer and not take into account pain caused by cancer treatment. If it includes either of these, the question is, and it's never answered in any of these policies, for what length of time is the patient's pain considered to be cancer pain? If you have someone who gets a chemotherapy that causes a peripheral neuropathy that's going to last for many years, for the rest of the patient's life, at some point, for the standpoint of these policies, does that become non-cancer pain, or does it continue to be cancer pain forever? And what about people with cancer whose most significant pain comes from a non-cancer cause? What do we do for those folks? And then we have the larger question, which we won't get into right now, but is it really a good idea to exclude cancer pain from a lot of these policies? Because after all, if the intent is to protect people who are being prescribed opioids, why would we not also want to extend that protection to people with cancer? So as I said, legislators like to legislate, and so since the CDC guideline came out, every state that's colored on this map has tried to legislate a limit on prescribing for acute pain. And you can see those limits range anywhere from a 3-day limit in 4 or 5 states all the way up to a 15-day limit. Now, some of these have passed, and so they're law in some states. For instance, in Kentucky, there's now a 3-day limit. Some of them have not yet passed, but you can see how active people have been in trying to turn these guidelines into laws. There have also been some that have legislated dose limits, and Maine is the most egregious example of that, perhaps. There's now a 100 milligram morphine equivalent per day maximum dose allowed for people in Maine. I will point out that they do make an exception for active and aftercare cancer treatment, and for palliative care, and for end-of-life and hospice care. But this is the tenor that we see, and we've seen this bill introduced now in Michigan and Pennsylvania as well, an attempt to really say you cannot prescribe more than X milligrams of morphine equivalent for a patient who has pain. This is just a very quick summary chart. I know you can't read it, and that's sort of the point of the chart, really. Each one of the little specks in here is a state that's got a policy that falls into one of these categories related to how physicians, and this is only physician-based, how physicians are to use opioids in treating pain. So you can see there's been a lot of activity over the years. We also see non-governmental regulation of opioid dosing because payers are a source of these sorts of informal regulations that can affect prescribing. We've seen payers set limits above which you have to have prior authorization. We've even seen some payers who've set limits saying that no prescriptions for an opioid above a certain dose will be approved. They can also set up fail first policies so that you have to try certain other approaches before you're allowed to use an opioid. You have to try certain opioids first before you use others that might be more effective or better indicated for the patient. And again, most of these exclude people receiving palliative care or hospice care, and many exclude people being treated for cancer-related pain. But that message doesn't always get through. You may know that Express Scripts announced a new policy a few weeks ago and specifically said they were excluding palliative care patients. And within a week, I had heard from several colleagues who work in the palliative care area saying that they were having problems because their patients were being denied their prescriptions. So just a final word, I think it's really incumbent upon us to want to be part of the solution so that we can provide pain care that's both safe and effective. Partly we have to make better use of the tools that we already have. Partly we need additional tools to effectively treat pain in ways that don't make prescription opioid abuse worse. And we need to be assertive in playing a role in developing the solutions that enable us to provide this kind of care. So I would encourage you to be active, to get involved with your organizations and look at what they're doing on the policy advocacy front and be engaged in that. So thank you very much for your attention. I'll turn this over now to Dr. Pace.
Good afternoon, everyone. This is quite exciting for me to be able to follow Bob's presentation, and what I'd like to do is extend some of the very important content that he just shared with you. So we're going to talk about management of cancer pain during this opioid epidemic, and Bob's given us a great foundation for this. I want to take a step back and just remind us how many people we're talking about. And Bob very nicely laid out this question about who is a survivor. But if we do look at all people who are living with a cancer diagnosis, there are quite a few individuals around the world. And the new cases of cancer are being born largely by the developing world, but the survivors are being seen more and more often in the developed world, like the U.S. And to what do we owe these wonderful responses? Well, I thought this is a great diagram here that illustrates how 100+ years ago, the best we could do to treat cancer was radiotherapy and surgery. And then there were some clever discoveries. Our soldiers were carrying mustard gas during the world wars, and scientists discovered that in those individuals there was a shrinkage of their lymphatic system, and that led to the discovery of nitrogen mustard to be used in lymphomas. And over time we had more chemicals being introduced, more chemotherapeutic agents, and around the 60s people actually started to believe there could be a cure. And in fact, early to mid-60s, we saw cure of some of the leukemias and the lymphomas. And then we even saw cure of a solid tumor, testicular cancer. And now, boy, we just can't keep up, or I sure can't keep up with all the many advances that seem to be occurring on a daily basis that continue to contribute to these amazing rates of survival. And now we have immunotherapy. For a wonderful review, for those of you who are really interested in the historical perspective, this is a fantastic novel called The Emperor of All Maladies by Mukherjee, and really gives a nice historical perspective about cancer discoveries. So that's the good news, that we have more treatments and they're leading to better survival rates. The bad news, as Bob described, is that some of these treatments are leading to more persistent pain syndromes. And unfortunately, we've got this opioid epidemic, which we've just heard about. So I've included a few diagrams merely to illustrate this amazing upward curve of survivors that we project to see and that we're currently seeing. And I love seeing in these colorful bars here, the green, the purple, and the aqua color. These are people who are living 5, 10, 15+ years. So a very different phenomenon than when someone like me first started practicing, when survival rates were really quite low. And for all of you on the phone working in oncology, you know that those who are survivors tend to be people with breast cancer, prostate cancer, colorectal cancer, and a variety of other malignancies, and that at least with breast and prostate, there's a pretty heavy burden of pain, both from the bony metastases that we see with these malignancies, but also from the treatments. And Bob gave us a great foundation to understand the drug overdose deaths and the opioid epidemic. So you can see the red states or the red areas simply exploding in the past 10 years. And Bob described the CDC guidelines as one effort to approach this problem of the opioid epidemic, and yet, as Bob described, these weren't based on evidence. And in fact, for those of us working particularly in the oncology arena, we were pretty upset about several of the recommendations. One of them, limiting the opioid prescribing to 50 morphine milligram equivalents per day, and that a prescription on discharge should only be given for 3 days or less. And when these concerns were raised to the CDC, it reiterated that this is not a mandate, it's a guideline. However, as Bob described, many of the insurance payers and now some legislators are looking at this as a mandate. And where all of us in clinical practice who prescribe are getting multiple messages from the insurance providers It doesn't matter that I'm putting the cancer diagnosis on the prescription. They're still being rejected, requiring prior authorizations, which require delays in care and lapses in treatment that can lead to problems with withdrawal, for example. So how do we achieve balance? And Bob gave us some interventions that we can employ. And I want to take that a little bit further, maybe a little bit more based in the clinical world, and that is first understanding this problem of substance use disorder, because all of us who work in inpatient or outpatient oncology are going to see people with addiction. And it's important to remember that this is not a choice and it is not a moral failure. So we have to be exquisitely careful about the words or the terms that we use. To call someone an abuser or a frequent flyer leads to judgment and punitive beliefs rather than the compassion that I know that we all carry within us. And in fact, yes, this is a disease of recidivism. It's a relapsing and remitting disorder, and lots of people are going to relapse. But I just wanted to put it into context. Lots of people relapse with diabetes, or with the treatment of their hypertension, or with their asthma treatment. And anybody who's ever tried to lose weight, you know what it's like to try to stay on a regimen. So this is a disorder that will lead to periods where people will be able to be sober and other periods where they will not. And in fact, recently published an editorial that appeared in the Journal of Oncology Practice, and I drew some similarities between cancer and substance use disorder. Many years ago, cancer was a disorder that was associated with stigma. People wouldn't want their neighbors or their loved ones to know that they had cancer. There was fear that if you touched someone with cancer or was with someone with cancer that you could catch it, for example. And there was a lot of blame. Oh, he was a smoker, it's all his fault, or it's something that he did. He didn't exercise. Well, we're seeing some of that same stigma and fear and blame associated with people with substance use disorder. And Bob mentioned some of the bills and the legislation that have been introduced. One is that the DEA is reducing opioid manufacturing by 25%. In fact, they're reducing the manufacturing of hydrocodone by a third. And just in the first 6 months of this year, 24 states have proposed 59 bills. And Bob gave you a sense of that with that very complicated table. Most of them are recommending enhanced education, guidelines, but more and more about time limits and maximum dosing. And most of these, or some of them, will exempt hospice and palliative care, but very few exempt cancer. Well, all of us in the oncology world are struggling with how to best manage chronic pain. And so the American Society of Clinical Oncology commissioned this guideline panel, and we did a systematic review of the literature. And our very first task was to define who is a cancer survivor. The National Coalition for Cancer Survivorship states that it's anybody from the moment of diagnosis. And although that's a beautiful definition, it didn't serve as a useful guide for us as we went to develop these documents. So we chose the NCI's Office of Cancer Survivorship definition, which is that survivor is a person with a history of cancer who's beyond the acute diagnosis and the treatment phase. But as Bob alluded to, it's fluid, and people don't fall into a simple box. And if you are just looking at survivors, the prevalence of pain appears to be approximately 40% or higher. So we developed 3 primary recommendations: screening and comprehensive assessment, treatment and care options, and risk assessment, mitigation, and universal precautions. And in the screening and comprehensive assessment component, we suggest that everyone should be screened at each encounter, asked about their pain. And there should be a comprehensive pain assessment done in response to that screening and at the initial assessment. Be aware of chronic pain syndromes that can occur from cancer treatment. And I've included some slides of that in just a moment. But always keep in mind that there is the potential for recurrent disease. And we've all seen it, that person with who's a long-term survivor from Hodgkin's lymphoma, for example, who was treated with mantle radiotherapy and now develops a sarcoma in the treatment field, as just one example. So in terms of those chronic pain syndromes, we see syndromes associated with chemotherapy. These include long-term adverse effects associated with corticosteroids, avascular necrosis. I had several 30-year-olds who already have had both hips and some of their knees replaced because of AVN. And of course, we see chemo-induced peripheral neuropathy. Hormone therapy can lead to arthralgias and even osteoporotic compression fractures. Radiotherapy can lead to cystitis, enteritis, proctitis, fistula formation, lymphedema, and a whole host of adverse painful effects. Stem cell transplant, primarily through graft versus host disease, can provide or produce an enormous array of very painful syndromes affecting every organ system within the body. And then, of course, we've known for a very long time about surgical-induced pain or surgical pain syndromes like post-mastectomy pain, post-thoracotomy pain, and even phantom sensation. So that first recommendation was to suggest good screening and assessment and making people aware of the universe of painful syndromes. The second set of recommendations very nicely aligns with Bob's recommendations to use non-pharmacologic therapies along with pharmacologic interventions. And when we talk about opioids, to enhance safe and effective prescribing. And we also try to make people aware of the long-term use and risks of opioids. So in terms of the non-pharmacologic interventions, Bob mentioned many of these: physical medicine and rehab like PT, OT, rec therapy, orthotics, heat, cold, integrative therapies, massage, acupuncture, music, interventional therapies like nerve blocks or vertebroplasty, and then, of course, psychological approaches. And I'm always telling patients that they would benefit from supportive psychotherapy, not because they have mental illness, but rather they are normal individuals who are struggling with crazy times, and they would truly benefit through discussing this with a skilled therapist and finding their own inner strength. And we also have neurostimulatory therapies like TENS units or spinal cord stimulation and others that are being developed. And because many of us in oncology didn't have the luxury of using opioids long-term for our patients, those of us with a few gray hairs, we typically would start opioids at the very end of life, and we never saw these adverse effects until we started to feel more comfortable using opioids for longer periods of time. We all know about the GI effects, but less is known about the hypogonadism and hyperprolactinemia that can occur from long-term opioid use. This can lead to quality of life issues like reduced libido and ability to perform sexually, and infertility may also be associated with osteoporosis and osteopenia. And then, of course, issues with neurotoxicity like myoclonus, and of course, sleep apnea. Our third set of recommendations revolved around risk assessment, mitigation, and universal precautions. And here we were advising people to understand tolerance, dependence, abuse, and addiction, as well as universal precautions. Alerting people to the components of a good risk assessment, which includes pain, function, past and current history of misuse of drugs, and that includes alcohol, smoking, gambling, And then what about family history? That gives us clues to the environmental exposure, and it's even a crude proxy to their genetic risk for substance misuse. And then finally, the question that it took me a long time to learn how to ask and feel comfortable asking was about a past history of sexual abuse. This is associated with PTSD, and it is probably one of our strongest risk factors for substance misuse. So to mitigate the risk, we use our prescription drug monitoring programs. And I believe 49 of the 50 states, I know there was legislation in the final state, and that was Missouri. Don't know if that's passed or yet, not or yet, but we have access to the history of the prescribing for all controlled substances for each patient. It would be lovely if this could be shared across all states, but right now it's a state-by-state mandate. We use pill count. We do urine tox. And in some centers, people do verbal or written agreements. We don't really prefer the use of contracts anymore. It's somewhat punitive, and from a legal perspective, it really isn't a true contract. So we assess and we stratify the patient's risk for opioid misuse, and we decide whether or not it's safe to prescribe. When we do prescribe, we want to minimize the risk, and it goes back to Bob's describing the multimodal care, using adjuvant analgesics, non-pharmacologic therapies, integrative approaches, and psychological support for the treatment of mental illness, anxiety, depression, and sleep disorders. We monitor drug-related behaviors, and then we respond to aberrant behaviors if they occur. And then finally, we need to educate patients about safe storage and disposal. It's possible that in the beginning of this opioid epidemic, many people with substance use disorder were getting the medicines from our patients. They were stealing them, and sometimes patients would share them. Now, the data suggests that 75% of those people who start out taking prescription opioids and then moving on to heroin, 75% of those people never had a prescription for prescription opioids. They had stolen them or purchased them from others or borrowed them. So it's really important that our patients understand that they actually might be targeted. They can't leave their medicines in the medicine cabinet. They can't leave them out on the kitchen counter, which is where most people do leave them. They should purchase lock boxes and keep them locked. And then from a safe disposal perspective, there are many take-back programs. It really depends on your community. I'm really fortunate in Chicago. We have a take-back program through our Chicago Police Department. No questions asked, and they incinerate so the drug is not getting into the water supply. There is information through the DEA about what to do if you don't have access to any of these disposal systems, and there is a twice-a-year National Take-Back Day, and the next one is just coming up in about 6 weeks. And what you do is go to DEA diversion, or you just Google take-back program, and you'll plug in your zip code and you can find out the programs in your area. I wanted to share with you a few very simple, real-life kinds of things that we did at my institution. We tried to standardize universal precautions, how our lab required the ordering and the processing of our urine tox, how we can access prescription monitoring programs directly through our electronic medical records so you didn't have to access a separate software package. We developed a standardized agreement so that clinicians who weren't really aware or comfortable with all of this didn't have to reinvent the wheel. And then making specialist access available, because this is a huge problem, so that people can advise colleagues who are running into issues. We had lots of education, professional, patient, and public. We have video monitors as patients are waiting for elevators or coming from the parking garage, and we placed some of these kinds of messages here about safe storage and safe disposal. And we're working on some pilot programs with disposal. We put it on our patient web pages so that the patients could see more specific information about safe storage and disposal. And we even put this on our Facebook page for the institution. So these are just some simple kinds of things that you can do. I wanted to finish up with a few bits of advice. Just, this is hard work, and this balance that both Bob and I have been talking about isn't easy. I'm going to be the first to admit it. So do learn about substance use disorders as a chronic disease. Learn about long-term recovery and the recovery advocacy movement. Be mindful of implicit stereotypes and biases. Consider the impact of our words and our behaviors. Talk with experienced colleagues so that you can move from frustration and mistrust to realistic engagement with some of the complex patients who have both substance use disorder and cancer pain. Learn and practice motivational interviewing, and don't worry alone. Find support to help you manage yourself and your patients. And it has become so clear to me that many healthcare professionals, either they themselves have SUD or someone they love is in trouble. Get help. It's available. So cancer survivors, not easy to define. It's a fluid term. All patients should have a thorough assessment. We want to use multimodal therapy, employ universal precautions, and safe storage and disposal are crucial. So I want to thank very much Rebecca and Bob and Peterson for organizing this conference and giving me the opportunity to speak with you. Thank you.
Thank you so much, both Dr. Judith Pape and Dr. Bob Twillman, for sharing your experience, your expertise, and some really important practical tips and advice. We have reserved time intentionally for questions from those of you who are participating in this webinar. And I hope that you will go ahead and type in the chat box. Peterson is keeping watch, and he can give you more specific instructions about exactly how to type in your question.
Great. Thank you, Bob and Judy. These were excellent presentations. My name is Peterson. I'm with NPAS, and I'll be assisting with this Q&A session. If you have any questions at all, please type them in using the question panel to the right of your screen. Bob and Judy, if anyone of you want to continue speaking as we wait, give it a minute or so. We had the good fortune of some of the questions that were asked at the start were answered along the presentation. So if you want to if you have something you'd like to keep talking about, and we'll give it about a minute to see how many more questions we can get in.
I can start with a question while Peter, yes, go ahead. Sorry, Judy.
No, go ahead, Rebecca. I was just going to ask Bob, did Missouri ever get a prescription monitoring program?
They got ever so close to finally getting it passed on the state level, but didn't quite get it done. The person who was the obstruction this year has resigned his seat and won't be in the legislature next year, so maybe next year. But in the meantime, what's happening is that the counties in the state and some of the cities are establishing their own prescription monitoring program network, so that by the end of, by the 1st of October, about 70% of the state population is actually going to be covered by a prescription monitoring program, even though the state hasn't gotten its act together yet.
There's never a dull moment. Just looking at that chart, Bob, with the tiny font showing the types of legislative proposal happening in the states that you and the State Pain Policy Action Network are monitoring every day and every hour. It's quite remarkable and more than a full-time job. I'm thinking about the different partners. I'm thinking about the other partners that can be part of the posse to help support the cancer practitioners who are participating in this webinar, and specifically each of you mentioned those in rehabilitation medicine who can also be helpful when you're trying to provide cancer-related pain management. I wonder if either of you have a real-world example of how oncology is partnered effectively with rehab to help support a person with cancer-related pain as a survivor.
So our Rehab Institute of Chicago has now a program for people with cancer to join their, if you will, it's like their gym. And because of the problem that Bob mentioned, PT is often not reimbursed. What patients can do is join this gym. It's actually the rehab area that's used for patients through the Rehab Institute. They pay a nominal fee, and they have classes and one-on-one physical therapy for people who are cancer survivors. I believe it's called Restore, as a matter of fact, and it's been developed in part because of the collaboration between Northwestern and RIC. We have a cancer physiatrist who is absolutely wonderful, who treats our cancer pain patients, and through these kinds of collaborations, they have been trying to fill the need. The other thing, when I have patients who really need exercise, physical therapy, or emotional counseling support, I recommend the cancer support centers or wellness houses in our community. And that's another real-world recommendation. It's not physical therapy, but most of these centers have exercise classes, Tai Chi, chair yoga. Many of them have massage, acupuncture, Reiki, therapeutic touch, support groups, and mental health counselors for cancer survivors as well as their loved ones. So that's another way to kind of fill in the gap.
Thank you, Judy, for that thoughtful answer.
Thank you. So it seems like what we're getting is a whole lot of thank you for sharing and some comments about the presentations. And we thank you all who joined us for the nice messages about the quality of the presentations. There's a survey at the end of this webinar, so I would encourage you to include those comments on there as well. Do you have a question, Rebecca? Yeah, and some of the comments that we're getting, Judy and Bob, just to share, and everyone else who's on the phone, finances can be a barrier with rehabilitation services, but many therapists have access to financial assistance options and are well versed in giving high quality services without requiring a lot of visits. Someone else mentioned that she would also stress that rehabilitation is much more than just exercise. We have at this center, they have manual therapy skills that help relieve pain and prevent issues down the road. And we have other comments along the same line that I thought I should share those too. And if you still have any questions, please send them to me, and I'll be happy to share them with Bob and Judy.
Bob, as you're looking ahead at the future in the pain policy world, what are the near-term things that keep you up at night that practitioners need to be aware of and be part of the solution as you both reinforced in your presentations? What are the places where we have an opportunity as caregivers of people experiencing pain that we might have a chance to take action and be part of the voices to help tell these untold stories?
Well, I can give you one very concrete example right now that's extremely worrisome. It's a citizen petition to the FDA that was submitted by a number of groups, including the Association of State and Territorial Health Officers, so it's the Association for State Health Secretaries and so forth. And the petition asks that, quote-unquote, ultra-high-dose opioids be removed from the market. And by ultra-high-dose opioids, what they really mean is any opioid that, when it's taken in the manner that it's intended to be taken, would exceed 90 milligrams of morphine equivalent per day. So in the case of OxyContin, that would be anything bigger than a 30 milligram OxyContin tablet would be taken off the market if these folks had their way. Anything larger than a 15 milligram OxyIR would be taken off the market. Anything larger than a 25 microgram fentanyl patch would be taken off the market. So there are opportunities for people to write into the FDA and tell them what a horrible idea that is. It's just such a challenge, and to me it seems as though it's akin to saying that maybe we could solve obesity in this country if we just limited ice cream to pint-sized containers. It doesn't make any sense. So those are the kinds of things that pop up all the time, and there are opportunities to weigh in on them if people can just get the information about when that happens and how to do something about it.
Thank you, Bob. Judith and Bob, we can't thank you enough. We don't seem to have any additional questions, and I can imagine that's the case because there was so much important and digestible material to think about. On behalf of all the partners, NPAF, ACCC, ONS, and COA, thank you ever so much, both of you, for sharing your expertise with us today. Again, this webinar has been recorded so it can be shared with your colleagues who couldn't dial in. And we hope all of you who participated will take the moment it requires to complete the evaluative survey when you log off. Thank you all again so much, and have a wonderful afternoon.